Welcome to the Bioethics Babe podcast, where we examine the tough questions in human flourishing in light of science, faith, and culture. I'm your host, Darina Grosso-Agnew. Now let's dive in. What is death? It's the moment a human being ceases to exist. But when is that exactly? We tend to think we know the answer, but what if the question is not that simple? Especially when it comes to brain death. What if the medical criteria we rely on to declare someone brain dead are not actually proving what we think they are proving? My guest today is Dr. Christopher DeCock, a pediatric neurologist and epilepsy specialist at Essentia Health, clinical professor of pediatrics at the University of North Dakota School of Medicine and Health Sciences, and adjunct bioethics faculty at the University of Mary, my alma mater. He serves as co-chair of Essentia's West Market Ethics Committee and was an observer for the Uniform Law Commission's drafting committee revising the Uniform Determination of Death Act. He has published extensively on brain death determination and has become one of the leading voices asking a difficult question. Are we certain that when we declare people brain dead, they are biologically dead? In this conversation, we examine what death actually is, the difference between organs and organisms, whether the current American Academy of Neurology criteria are adequate, the distinction between irreversible and permanent cessation, and what is at stake if we get this wrong. Because if there is a thin line between being dead and being alive, we had better be sure we know where that boundary truly lies. Dr. DeCock, welcome to Bioethics Babe. So let's discuss medical definitions of death. And clinical tests don't define death, they confirm it. What does that distinction mean?
Well, basically, when we look at any test in medicine, we look at how good is that test at doing what it's designed to do. So, for example, if you have a test for lupus and it does a bad job of confirming whether or not the patient has lupus, because again, lupus is an objective reality, and if this test doesn't actually confirm that, it's what we would call a bad test. Now, we know that what we should do in that case is try to improve testing, right? We want to increase the terms we use, our specificity and sensitivity of the test to, detect this disease, right? This objective reality, right? So we're using, this test in order to determine what's going on. Now, it doesn't work the other way around. So if you've got a bad test at diagnosing lupus, that doesn't mean the patient doesn't have lupus, nor does it mean that the test is what determines reality, because the test is just that. It's a test, right? And no test is perfect, right? There's no such thing as absolute certitude in medicine. We know that, right? We know that we're never going to have 100% sensitivity and specificity, and we're never going to have that in life either. So for example, people talk about the cardiopulmonary death standard and say, oh yeah, we had 100% certitude. Well, no, we didn't, because if that was, why on earth were people who were determined dead buried with a rope with a bell tied to it so that if they woke up in the coffin, they could ring the bell? And that's where the expression "Saved by the Bell" came from. So it's not from the 90s sitcom, it's from accidentally being buried. So there's no such thing as absolute certitude in medicine. And so ultimately, tests do not determine objective reality. So if we look at the AAN clinical guidelines, right, what happened in the UDDA revision is that the American Academy of Neurology wanted the standard of death to change from irreversible loss of functions of all parts of the brain, including the brainstem, to permanent coma, permanent apnea, and permanent loss of brainstem reflexes. Basically, they wanted the letter of the law to be their clinical test. And so they were saying that we say you're dead, therefore you're dead. Well, that's not biological death. That's what we call a functional stipulation, right? I've decided that you're dead enough, and therefore I'm going to declare that you're dead, even though you might not be dead. So what's the reality? So what should you do in medicine? So if you have a bad test that doesn't do what it's supposed to do, you're supposed to improve testing. So if we look at the case of Jahi McMath, because she's the most, you know, obvious case of this, after she was determined to be brain dead, she, if she was dead, she is no longer a human being and she is a corpse, right? And there are certain things human beings do and certain things that corpses do. Well, she underwent puberty. She was at home maintaining homeostasis for 4 years on a ventilator. And so I have a really hard time believing then that even though the test said she was dead, that she was actually dead. And so in medicine, we have a term for that. That would be what we would call a false positive, right? So you're saying they're dead, but they're not actually dead. And so what we should do is not change the standard of death to make the criteria correct. We should improve those criteria to make the standard to detect the standard. Does that make sense?
Yes, and we'll definitely get into the actual criteria. Before we go there, you spoke a little bit about cardiopulmonary death and how obviously there in the past, even people who were declared dead by those means could still be alive. So most people would think that cardiopulmonary death is largely based on common sense reasoning and experience. Is it philosophically clean, and is it medically clean to when you state that someone is dead because of the cardiopulmonary loss?
Well, so it could be clean. Now, we'll talk about this later with the terms permanent and irreversible. The other thing the AAN wanted to do is they wanted to change the cardiopulmonary standard from irreversible loss of cardiopulmonary function to permanent loss of cardiopulmonary function. And now is as good a time to say what that difference means. So, irreversible in the medical literature means cannot reverse. Permanent means will not reverse. We know that the heart, when it stops, can undergo what's called autoresuscitation. It can restart spontaneously. And we know that it can occur up to, in some cases, 10 minutes after the declaration of death. Well, if the heart restarts, then that patient wasn't dead when we declared them to be dead, right? Now, here's the thing. When someone goes down in the hospital, you hear this term, we're calling it code blue, right? We're doing CPR on this patient. Well, you also know that people can have what's called a do not resuscitate order, right? So you could restart my heart, but I don't want you to, right? And so now all of a sudden, cardiopulmonary death is no longer necessarily an objective thing. It's something that's sort of we're deciding. It's sort of, is getting pushed into that subjectivity. And part of the impetus to do that is because of a procedure called normothermic regional perfusion, which I won't discuss at this time. I know you want to potentially discuss this in a future episode, but there are procedures that, make that a desirable thing. So common sense is common, but it's not that common. And so we know, for all of human history that this could be the case, right? And so cardiopulmonary death is definitely a safe standard, but is it the best standard and is it entirely philosophically clean? No. Because again, there's no absolute certitude.
And to your point though, I guess the follow-up question to that is it possible for someone's heart to stop beating and then obviously either it automatically starts on its own or with medical assistance they can assist the heart to start beating again? And when the heart stops beating, does that mean that that person died? Or what how would you define that?
Well, like I said before, the heart stops beating, right? If the heart does not restart, then you can say, well, good, my determination of death was correct, right? It didn't restart. If the heart restarts on its own, well, then my determination of death was not correct. Does that make sense?
Yes. And if it doesn't start on its own but with help, how does that determination weigh in?
Well, if it can be restarted, I would say that you probably weren't dead then. And again, that's what happens in that procedure called normothermic regional perfusion. Basically, after you're declared cardiopulmonary dead, right, then what they do is they use a heart and lung machine to resuscitate you. And the whole point of that is they want to get organs. But they've said you're already dead. And so then there's other things they do, such as, you know, clamping off or cutting the blood flow to the brain to ensure that the brain isn't perfused and stuff like that. Well, to me, now we're objectifying patients. We're trying to play God, and we're not really sticking with biological reality.
Wow. Yes, and we'll certainly have you on the show to discuss that at length. Now let's pivot to brain death itself. Is brain death really death? Why or why not?
So there's three camps. Okay. So there's one camp that says no, brain death was totally made up. And basically what happened is in 1968, a group of people met in what was called the Harvard Ad Hoc Committee and said, look, we are going to declare that this group of patients is now dead. There was no philosophical reasoning. The only quote in this expert consensus paper was not even a medical quote. It was a quote from Pius XII saying that the church couldn't make a medical determination of death, which is correct. The church should not be making a medical determination of death. The philosophical rationale for that idea didn't come around until 1981. And that's where the idea of the brain as a master integrator came. That's when the UDDA was promulgated into law. And then from that, what happened is you had all these cases that seemingly were alive after they were declared dead. And so at that point in 2008, the President's Commission, rather than saying, hey, we need to improve our testing, they said, well, we're going to change the rationale for death from self-integration to vital work. So basically, if you're unable to do vital work, if you can't think and you can't breathe, then you're dead. But as we talked about earlier, that's what's called a functional stipulation. Now, the American Academy of Neurology practice guidelines are based on that functional stipulation. Basically, that if you can't breathe and you can't think, you are dead. And what's interesting is about when they came up with the new practice guidelines, it even said in there that they reviewed relationship disclosure forms and curriculum vitae for financial and intellectual conflict of interest. These documents were specifically screened to exclude those individuals with a clear financial conflict. That's a good thing. And those whose profession and intellectual bias would diminish the credibility of the guidelines in the eyes of the intended users. So basically, if you didn't agree with the 2010 AN clinical guidelines, you weren't allowed at the table to determine what the 2023 guidelines were. So it's basically just an echo chamber. And so I'm sorry, I went a little bit into history, but back to those three camps. So basically, you've got the one camp that says, look, brain death was made up. There's no way that brain death can be death. You have the other camp that says brain death is fine. The criteria are fine. Those people I call the partial brain death people. You could call them functional stipulation. You could call it vital work. But then you've got people like myself and my colleagues at Georgetown and elsewhere who believe that whole brain death could be death, but unfortunately, we don't have any prospective data. We've got retrospective data, but not prospective, meaning looking forward to say that that is indeed the case. And actually, they're working on obtaining prospective data at Georgetown right now. And so to me, is brain death really death? I would say brain death could be death. However, the data may show that I'm wrong. But at this point, whole brain death seems to meet that standard of moral certitude or prudential certitude that, yes, when you have whole brain death, when you lose homeostasis, when you lose mind-body integration, when you lose respiratory integration, the data, retrospective data granted, tells you that these patients are no longer living their corpse. They are no longer self-integrating. Um, and what's shocking, though, is some of my opponents at the UDDA, other observers, were pretty blunt about this. They said, look, we don't believe that brain death is actually death, but it doesn't really matter. If someone wants to be an organ donor, they should be allowed to give their organs, because if we don't respect their autonomy, we're harming them. So I'm going to give you a quote from Trug and Miller from '08. They said that, and I quote, "The uncomfortable conclusion to be drawn from the literature is that although it may be perfectly ethical to remove vital organs for transplantation from patients who satisfy the diagnostic criteria of brain death, the reason it is ethical cannot be that we are convinced that they're really dead."
Wow. So, based on all of what you've been saying about brain death, and especially about whole brain death, how confident are you that current clinical criteria actually and accurately identify it?
Well, they don't. I mean, I'm very confident that they don't, because like I said, because of the false positives. They diagnosed Jahi as brain dead. She was clearly not brain dead. They diagnosed this gal in Georgia who was gestating a pregnancy. Corpses don't gestate pregnancy. I'm sorry, right? They just don't. That's nothing that a corpse does. But they said, no, she's dead. We've said she's dead. And therefore, we can terminate the pregnancy, or we can continue it based on what the people want.
Well, some of the guidelines that the AAN relies on are coma, absence of brainstem reflexes, and apnea testing. Do these tests truly demonstrate loss of whole brain function?
No, they do not. Because, like I said earlier, they leave out the part of the brain that is responsible for homeostasis, right? They leave out the part of the brain that allows people to maintain temperature, hormones, stress responses, emotional cognitive processes, phenomenal awareness, and they know they're leaving them out. And in fact, the guideline says that even when you have this functioning, you can still declare them to be dead, because we think this functioning is not important.
And how does that functioning operate? Does that come from the brainstem, or where in the brain does that happen where it allows for homeostasis?
Well, so the part of the brain that's associated with that is what's called the hypothalamus. So it's not in the brain stem. It's in front of the brain stem, but it's at the bottom. It's sort of at the base. It's it's attached to your pituitary gland. So it's very, very deep in the brain, very protected. It actually has blood flow from both inside and outside of the brain, because it's such a vital part of the brain. And another part of the brain that we can't test for is a part of the brain that's right next to it called the thalamus. Well, that's where all sensory inputs have to go through that part of the brain before going to the cortex. And we have no way of testing that part of the brain either. We do have or I shouldn't say either. We can't test the thalamus, but we can test the hypothalamus.
But testing the thalamus or the hypothalamus is not part of the current AAN guidelines?
No. Again, you can't test the thalamus, not that I know of anyway. Maybe you could do functional MRI testings and see if that area lights up. I don't know. But I know you can test the hypothalamus, and it can be as easy as looking them at the bedside. So one of the things that when someone doesn't have a hypothalamus, they'll undergo what's called diabetes insipidus. So basically, they just are dumping fluid. They're wasting fluid out of the urine, right? So it's very, very dilute, and it's just pouring out. That's called diabetes insipidus. Now, the problem with that is, like Jahi McMath had diabetes insipidus at the declaration of brain death. But then later on, the diabetes insipidus resolved. So you know then that the part of the brain, the hypothalamus, was damaged, but it happened to recover, right? And that's really the problem that we see, is that damaged tissue can recover. And so we really need to be giving these patients time when we're determining when they're dead.
And in the case of Jahi McMath, how long did it take for her body to recover what was damaged? And how long would you recommend to give patients? That's my first question. And the follow up question is, has the AAN publicly or privately that you know of discussed why they won't include testing of the hypothalamus, and if there are any tests that can be done on the thalamus as part of the guidelines?
So I'll answer your second question first, okay? So the AAN basically has taken the stand that the hypothalamus doesn't matter, that neuroendocrine function doesn't matter, and that you're dead anyway. Because remember, the AAN clinical guidelines are not based on a whole brain death standard. They're not based on a biological standard. They're based on a non biological standard. So basically, if you can't think and you can't breathe, you're dead enough to be declared dead, right? So they don't care about that function. And in fact, in the new guidelines, they even use some tricky language. So they pivot and don't use the term whole brain death, but they use the term brain as a whole. Now that's a little disingenuous because it's basically saying we're going to test for the parts of the brain that we think are important. So on the whole, we think these parts of the brain are important, but the rest of them we're going to ignore. And so they're sort of using language, using the trust that whole brain death has had in order to sort of push their criteria, which again are a non-biological criteria. And so they frankly don't care. And it's sad to say, but again, it comes back to that first concern I had that, this really sounds like life unworthy of life to me. And that's frankly what it is.
And what are your primary concerns with the 2023 AAN update?
Well, before I answer that, I first, Jahi, how long did it take her to get that hypothalamic functioning back? It actually took longer than most people would want to wait. I think it took like a year and a half. And so improved testing can't just be looking at just the hypothalamus, although that would improve certitude significantly. But we need to look at other things as well to determine, whether or not someone is dead. And that's going to be the benefit of doing the prospective data is so we'll say, well, okay, this patient came in with this injury and then they progressed to brain death. This patient had this injury, but they didn't. Okay, so what is it about this? What is the best test? So, what tests to do, we don't know yet. But like I said, you can clinically tell at baseline whether or not someone has hypothalamic functioning or not. And I know that, when we look at the retrospective data, that at least half of the patients determined to be brain dead by the current clinical criteria have hypothalamic functioning just because they're not in diabetes insipidus. And
And
then now your next question, what are my primary concerns? Well, my primary concerns about the AN guidelines are it's not that they're bad, they're just incomplete. And I think my main concern is they're really doubling down on sort of this non biological determination of death. They're switching from irreversible to permanent in the guidelines. They don't recommend waiting long enough. They don't offer any outs. Well, for the apnea test, so if the patient doesn't want the apnea test, they're, you know, they're not really willing to go around that, even though there's other tests that you can use. And so basically, the apnea test basically looks at your ability to breathe. And the problem with the apnea test is if you do it too early, there's brain swelling that's going on, and you can have a false positive again because of all this swelling. Not only that, there is some data. Now, I'm not sure how great the data is. It's questionable, but there's some data that when you do an apnea test early on, you can actually kill these patients. And so there's no informed consent for that. Now, a test that doesn't provide a therapeutic benefit should have consent anyway. I mean, if I go to get a mole removed, I have to fill out a consent form. So why are we not having people filling out these consent forms? Why are we not being transparent about this information? And so there's a number of things I'm concerned about, but overall, the AN guidelines are very good at determining brainstem death or partial brain death. They're bad at determining whole brain death. And so there's multiple things I would recommend doing to improve those guidelines.
And this would be the perfect time to tell us what those are, because maybe we should just present those to the AAN.
Well, we did at the UDDA and we were rejected. But basically, when I look at the guidelines, now this is just me, as a neurologist from Fargo, North Dakota, what are things I think we should be doing? So, for example, they recommend waiting only 24 to 48 hours. Well, to me, that's balderdash. I learned early on that brain swelling occurs after brain injury. And the reason brain swelling occurs is when a neuron is damaged, it can't maintain a concentration gradient. So basically, it has trouble maintaining between the inside and the outside of the cell. Well, what happens then is that the neurons will start to swell. So that's why I say brain swelling. The term they use is edema. The technical term is cytotoxic edema. Well, we know that brain swelling is maximal at around 72 hours. So any determination before 72 hours would, be at risk of being a false positive, and it would put you at risk for that global ischemic penumbra. The other thing is we need to be testing the hypothalamus, right? I don't know what that test is, but we really need to make sure that hypothalamic functioning is lost. And ideally, it would be great if we could determine, the hypothalamus is only injured in this case, but it's actually dead in this case. For example, one of the gold standards that we could do is what's called a 4-vessel angiogram. So you basically look at the blood flow from, the 4 vessels going up, to the brain. And we know that's the gold standard, and the AN even says it's a gold standard, but they don't require that gold standard. Well, when we're talking about life and death, I think we should be requiring that gold standard. And in the past, I didn't want to do it because it wasn't readily available. But it is now. It's something that they use all the time for stroke patients, so it wouldn't be too big a move to do that. The other thing I think they ought to do is not only should they be waiting 72 hours, but I think they need to repeat examinations, right? Because I said before, human beings are human beings, corpses are corpses, human beings do human being things, and corpses do corpses things. Well, one of the corpse things that corpses do is they decompose, right? They lose integration, right? They cease to be what they were. Right. And so if you were to repeat an exam, so let's say you waited 72 hours, you did an exam, and then you waited 24 hours and you did another exam. Well, in that 24 hours, the patient should be getting worse. They should not be getting better. If they're actually dead and self-integration is lost, they should be getting worse. And so what I would say is if they are stable or they're improving, then you couldn't say that they're dead. And then, like I said earlier, I would want informed consent for that apnea test. And if they did those things, which again, these are not heavy lifts, I think we would have much more certitude in the determination of brain death, specifically determining that patients are whole brain death.
Yeah, it's absolutely mind-blowing to me that the AAN would allow declaration of brain death even, as you mentioned, in the presence of neuroendocrine function. Obviously, as you mentioned, the hypothalamus can regulate temperature, hormone, stress responses, and all those things should be taken into consideration when determining if someone is brain dead. When you reference data about this suggesting retained hypothalamic function is common, does this undermine the claim of cessation of all functions of the entire brain?
Yes, it does, because the hypothalamic function is a function. And what's even more important is from a clinical standpoint is we know that these patients with retained hypothalamic function can feel pain and they may have phenomenal awareness. So if these patients are going down to be organ donors, they are aware on some level and feeling pain because we don't anesthetize these patients because we've said that they're dead while we're extracting the organs. So you mentioned do no harm before. Well, I hate to say it, you are definitely harming the patient by not doing that. And to me, it's mind blowing because improving testing isn't difficult. It's just people don't want to do that. So, for example, I talked about increasing testing at a hospital system, and they said, "Well, no one else is doing it, so we're not going to do it." Well, that's bad medicine. That's lazy. Is fundamentally what that is, and that's a lack of care for patients.
This should be alarming to everyone listening, because these tests, as you said, they're not extraordinary tests, right? These
Nope.
are just tests that can be done as part of criteria to find out the status of someone's brain, especially if it's a loved one and you don't know exactly where they are and how they're doing. So, can you explain a little bit about the difference between whole brain death and the AAN's use of the phrase brain as a whole?
So, like I said, brain as a whole is basically partial brain death. So, brain as a whole is basically, I want to only test these parts of the thing. It's like you said before, they're trying to make the testing the standard of reality. Well, tests don't define reality, tests reflect reality, and bad tests do not reflect reality. And so, you know, basically by ignoring this part of the brain is they're basically saying they don't care. Now it's not just the AN either. There's many good Catholic physicians out there who thinks that the status quo is just fine. To me, it's surprising that, like I said, you don't have to dig very far, and we have all of this retrospective data that shows it is a problem. But a lot of people I respect feel that it's great. Like Jason Eberl at St. Louis University is totally fine with the current criteria. Wes Ely down in Tennessee is totally fine. Even Bishop Olson, who was in charge of the ERD revisions, thinks that the standard is totally acceptable. And I don't understand that. I really don't understand that. Because to me, we don't have certitude that we're doing the right thing. We're potentially harming patients, right, by killing them, right? And we should have better certitude, and we don't. And so, I think people get caught up in what's called teleopathy. It's sort of the pathology of the goal, right? Organ donation is such a great good. It's such an amazing thing that we can do that we forget the collateral costs, right? We forget that these are patients. These are not just organs. And so, accepting a partial brain death standard is, a non-biological standard, right? Which hopefully you agree with me after we've discussed. This is a functional stipulation. But what's even more interesting is if you go back to John Paul II's um, allocution on transplantation, he said that brain death seems to be consistent with a sound anthropology. So it wasn't a carte blanche. Yeah, brain death is death. But he said, but only with complete and irreversible loss of all function of the entire brain. And what shocks me is that the UDDA is basically what John Paul II said. And I'm like, wow, this is amazing. We got a Catholic law, but we may not have it for that much longer.
Right. And basically, just to clarify for our listeners, the current criteria, when all is said and done, the results of that, it was really a diagnosis of a partial brain death, and your argument is that we're not really diagnosing whole brain death as we should because of all these other criteria that we're missing out on. Is
Correct.
that correct?
Right. And so the whole point the UDDA met to look, the ULC met, so the Uniform Law Commission met to revisit the Uniform Determination of Death Act, which, by the way, that revision has been placed on a permanent hold, so it could come up again. But the whole reason is that we know that the clinical criteria do not hold the letter of the law.
And well, that's very important to state, because so how does that work with the current letter of the law if the current criteria doesn't uphold it?
Well, one of the things the AEN has done since the UDEA put the revision on hold, which, by the way, they put the revision on hold a month before the AEN released its new clinical guidelines, is they've been going state to state trying to get the states to make their criteria the standard for death. So just because they did not succeed on a national level, they're actually going state to state now. Now, the nice part is they published their data, and it looks like most states are not actually interested in changing the criteria. So, for example, in North Dakota, they went to my state health officer, and so they went to North Dakota Department of Health and Human Services. And basically, my state said, look, we don't, want to make the AN guidelines basically the acceptable medical standard. And that's what the AN wants. They want the states to say, hey, the 2023 guidelines by the AN or its future organization or its future guidelines are the legal standard for the determination of death. And so the term they use, they said, quote, the most recent consensus practice guidelines published or endorsed by the American Academy of Neurology or successor organizations. So what happened, and the reason they're going state to state is there was a case in Nevada. So a girl was determined to be dead in Nevada. I believe it was a girl. I think it was Hailu was her name. And her family said, we don't believe she's dead. And so they went to court, and the family actually won. And the reason the family won is because the law just says an accepted medical standard, because it doesn't specify a standard in the law. And there's a reason for that. We discussed this in the Uniform Law Commission. It's because standards change, right? And there can be more than one acceptable standard. Well, what happened is after the family won and her declaration of death was rescinded, then Nevada state court met, and then they changed the law to say that the AEN guidelines are the standard of the law. So if that were to occur now in Nevada, they'd say no, because the AEN is the standard guidelines.
And so this is also troubling because different states can accept different standards, but also the fact that the AAN is the current quote unquote standard, that puts a lot of people at risk, especially some of these people that you mentioned. Leaving it as general as saying that death can be determined quote unquote in accordance with accepted medical standards leaves a lot of questions, right, to be asked. And also a lot you could see where there could be arguments between families and healthcare systems as to how to determine if their loved one is actually dead. Is that correct?
Mhm. There could be, but again, leaving it vague, I think, was very wise on the part of the lawyers, because again, standards change as technology progresses. Standards do change, right? You have to update your standards from time to time, and there are multiple acceptable standards. One thing, for example, that New Jersey did with their state law is they have a very big Ashkenazi Jewish population, and they don't believe in brain death because they think that the heart must stop, the heart and lungs must stop for declaration of death. And so New Jersey actually has an opt out in the state law. Now, a lot of people are like, no, we can't do that because we're going to get all of these patients who meet the criteria of death but are not dead, and we're going to overwhelm the hospitals. That's not true. Okay. People looked at New Jersey. This law has been in place for a long time. It's it's rarely used. And I think if someone doesn't believe in brain death from a religious or a philosophical standard, let's say you're from an Eastern religion that doesn't place death within the body, right? Then you should be able to opt out. We shouldn't be colonializing our views, even though I think that whole brain death does, point to objective reality. And if you do meet the criteria of whole brain death, it's not going to be a long time before cardiac function is gone too,
Hmm. So
because
from
corpses don't indefinitely maintain cardiac function.
right. And so who decides what is accepted? Are you saying that because it's vague enough, the states can decide for themselves? Um, how should these be decided, and who decides what is the accepted medical standard?
Well, so for example, right now, the AN guidelines are probably the most widely used standard, right? So if the law were not written the way it were, right, if the law were written like the way it is in Nevada, that would be it. So if the guidelines are bad, you're stuck with that. By leaving it open, then now someone like me can say, look, you know, I don't believe that this patient is actually dead because we're not actually testing hypothalamic functioning. I've got this data to back me up. It allows for a physician, allows for a family to object to a determination.
And I think that's important, and especially as we continue to improve technologies and ways to test people, and hopefully the criteria is going to continue to be updated as these things as technology improves and as we can see the function of this part of the brain that is right now not being considered as part of the criteria. You mentioned this earlier that there's a difference between permanent cessation and irreversible cessation, but can you speak a little bit more about why those two terms are not equivalent?
Right. Okay. So take it for what it's worth. The guy who defined irreversible and permanent is also the guy that defined the brain as a whole. So, take that for what it is. But in the medical literature, permanent means will not reverse. Irreversible means cannot reverse. So in cardiopulmonary death, permanent could be acceptable because, again, like I said, we allow people to have DNRs. We could intervene, but we're not going to intervene, right? And that is not necessarily a morally problematic thing. Well, in the case of brain death, in order to determine someone is brain dead, you need to rule out reversible causes. So if you're ruling out reversible causes, then this must be something that's irreversible, just, you know, based on the word in and of itself. The other thing is we know that when brain tissue dies, not when it's damaged, but when it dies, what happens is the brain will swell and the neurons will burst and the fluids will be flushed out of the brain and the system by the cerebral spinal fluid because it's got a flow in there. And so it really is irreversible, right? Because once a neuron is dead, a neuron is dead forever. That's why strokes are a problem, right? Once those neurons are dead, those neurons are dead. And so it's not permanent, right? It's irreversible. And the thing is, you know, permanent, like I said, could potentially be acceptable in cardiopulmonary death, but irreversible is definitely the safer term. It is the term that is most grounded on objective reality.
And does redefining death as permanent instead of irreversible make death partly dependent on our decision not to intervene?
Yes, it does. And remember, the AEN changed their guidelines from 2010 from irreversible to permanent.
Okay, we're going to pivot now to discussing the mind, body, and integration a little bit more. Why is higher brain death insufficient?
Well, that goes back to what we talked about earlier about the fact that we are not just minds accidentally inhabiting bodies, right? We are embodied souls, right? And so the body does matter. If you think that the body does not matter, like Socrates, where the body is holding, the soul in shackles, and you need to free yourself from the body, or like Descartes, who was like, I think, therefore I am. That's what makes me a human being. Then that's denying the importance of the body, right? So right off the bat, so metaphysically, it's problematic ground. The other thing is higher brain death, right, is basically, it's kind of like that vital work thing, right? It's saying, well, you're no longer a human because you can no longer think. And therefore, we're going to create a subclass of humans that now, you might be biologically alive, but we don't consider you human anymore because you can no longer exercise your autonomy. And therefore, society will attribute value to you, which of course violates every individual's intrinsic human dignity, because accidental qualities of whether or not, you know, we can move, whether or not we can think, whether or not we can express our autonomy shouldn't matter. We are human because we're members of the species Homo sapiens. And so higher brain death is problematic from that standpoint. It's basically changing the goalpost from biological death to non-biological death, even though you could argue that the AN has already changed the goalpost, but it would be further moving that goalpost down the line.
And I think that's a very scary, slippery slope because you can think of people who have intellectual disabilities or who are in persistent vegetative state where the higher brain function may be damaged, but they,
Mhm,
as you mentioned, they still have equal value and equal dignity as human beings. And just
mhm.
because the higher brain functions aren't there does not mean that they should be treated with any less respect than anyone else.
Absolutely. And in fact, I mean, this sort of rationale is used all over. So for example, in the Netherlands, I'm sure you've heard of the Groningen protocol. Basically, if you feel that your child will suffer in the future, you can kill them up to a year of life. And that's been in their law for years.
Yeah, that's crazy. Is loss of consciousness the same thing as death?
So I would say no, right? I would say, so irreversible loss of consciousness is not the same thing as a coma, right? So by definition, a coma is something you can get out of. This is something different, right? So this is sort of that loss of mind body integration. Now, actually, it was interesting when we first met at the UDDA, the recorder for the UDDA for the committee, who was sort of running the show, basically proposed that we define death as loss of consciousness, permanent loss of consciousness. And you can imagine a lot of people were like, oh my goodness, what are you doing? And luckily, common sense prevailed that day because basically we can't actually measure consciousness, right? We can measure a part of consciousness that's called awareness. But like I said, in patients like Jahi, um, with a functioning hypothalamus, we know that they could have a phenomenal awareness of what's going on as well. And so we can't actually measure loss of consciousness. So to use that as sort of the standard of death would be extremely problematic. And again, the reason that's even considered is because, again, if you can't think, then you're no longer considered to be human. But again, that's violating intrinsic human dignity, and that's relying on attributed dignity, where society decides that a group is not human. I mean, that's what happened with slavery. That's what happened with human trafficking. That's what happens when you deny people the right to vote. I mean, we've done that before and it's never worked out well. So I don't think we should be doing it again.
Right. And I think that just even common sense will tell you someone who loses consciousness is not dead, right? Someone can pass out briefly and come
Mhm.
back. So just even that idea is scary to think that that definition was even considered as something that could define death when obviously it doesn't. You distinguish integration from coordination. Is hypothalamic function coordinating or integrating?
Well, I would argue that hypothalamic functioning is integrated. And actually, I don't define the difference between integration and coordination. That's Marie Kondo's idea. So, Maureen doesn't think brain death is death because she states that hypothalamic functioning is just merely coordinating. So, the philosophical question is basically, you know, is this persistent hypothalamic function, is this persistent integrated vegetative functioning of the whole, or is it residual non-integrating functioning of parts? And so, in fact, Jason Eberl's PhD student, Bernendez, just released an article criticizing Dr. Solmesi, myself, and our colleagues at Georgetown, saying that we were illogical for caring about this because that functioning doesn't matter because it's coordinated. Well, if you look at Marine's definition, so she sort of defined the difference between integration and coordination. So in order for a function to be integrating, she states it needs to be multifaceted and involve every organ system within an organism. I would argue homeostasis is that. Therefore, I would say that functioning is integrating. She also argues it needs to be context dependent, especially in severe illness, which organs may be failing, but homeostasis is sufficiently maintained to support life. Yes, hypothalamic function, neuroendocrine function does that, so it's integrating. It must reflect the conditions of the whole, as the whole cannot exist without it. Well, if you don't have homeostasis, you're not going to exist. So I would argue that it is integrated. And it must also regulate the activity of systems throughout the body for the sake and continued health and function of the whole. Yes, that's what hypothalamic functioning does. Without temperature regulation, without pain detection, without homeostasis, you're not going to function as a whole. So I would argue that it is integrating by all four standards sent out by Conduct, even though she states that she doesn't believe it is.
Mhm. And how does entropy and allostasis come into discussion of death? What does it mean for entropy to overwhelm homeostasis? And again, if you can remind our listeners what all these terms mean
Sure.
as well.
Sure. So entropy again is chaos, right? So it's the tendency of things to disorder, right? It's what the second law of thermodynamics, I forget. Physics, I took physics, but that's all I can say is I took physics, right? Allostasis and homeostasis can almost be used interchangeably. So allostasis is basically the term for organismal homeostasis. And so when I'm talking about homeostasis, that's the control, right? It's the ability to maintain the systems in the whole, right? To help to have that environment in which all of the organs can work together, where all the systems can work together, where all those spheres of integration can work together. And so, like I said earlier, when we think about, philosophically what death is, right? Death is ceasing to be the kind of thing that you are. And if you look at it biologically, so there's a gentleman, his last name is Nair Collins. He argues that, that's death, is when entropy overwhelms homeostasis, when chaos overwhelms control. And that actually biologically makes a lot of sense because that's what loss of self integration is, right? You are no longer a unity identity whole, right? And so you cease to be the kind of thing that you are. So you are no longer able to maintain your homeostasis. You're not able to maintain your unity identity wholeness, and you have ceased to be the kind of thing that you are. So you're no longer a human being, but now you're a corpse.
And are there other things to look for when you're saying that biologically, and you can say with prudential certitude, this organism no longer exists?
So, you know, first of all, I'd mentioned, sort of what prudential certitude is. And so you'll notice in the new ERD revisions, they talk about moral certitude and prudential certitude. I actually wrote a paper for National Catholic Bioethics Quarterly, talked about, you know, upholding or promoting prudential certitude by ensuring that we're testing for whole brain death. And so what I would say is biologically, if an organism has lost self-integration, if homeostasis has been overwhelmed by entropy, we should see clinical signs of that, right? And if we're not seeing clinical signs of it, that's why I said, if we were to repeat testing over 24 hours and the patient was stable or improving, I would have a hard time saying that individual was alive or was dead. because if they're dead, everything should fail, right? Or already failed.
Yes, and I want to take a look at some cases. We already discussed Jahi McMath a little bit. Before we turn more towards her case, let's talk about Terri Schiavo. She was in a persistent vegetative state, and there was a whole legal battle about whether or not to take her off of life support. Some will claim that she was brain dead. Is that accurate? How does
She wasn't
persistent...
brain dead.
Right.
There's no way. There was no way, because all she needed to do was be fed, right? So brain death and persistent vegetative state are not the same thing. Now, there's a different term for persistent vegetative state. It's actually a kinder term, but I forget exactly what that term is now. But no, she was not brain dead. And in fact, the day that and I'm going to be blunt, she was starved to death. The day that she died is actually coming up. It's March 31st. And I think she is someone that we can look to and realize that, these patients are being marginalized. There are talks about, like, if you were to reclassify death as loss of consciousness, well, now all of these patients with persistent vegetative states would now be dead, right? Even though they're biologically alive. And so then again, that's a society deciding who's alive and who's not, and that should never happen.
And we don't even actually know what kind of consciousness she had. She may have not had loss of consciousness, right?
Correct. Right. Because again, we can test awareness, so we know she wasn't aware, but do we know if she was conscious or not?
Right. So how does persistent vegetative state differ from brain death?
Well, so I would say that persistent vegetative state, clinically, they're not intubated, they're not in the ICU, right? So that's one big difference clinically, right? They're not, very extremely ill, right? They're basically, you know, they lost, what we would say they appear to have lost mind body integration. Again, we don't know how to test consciousness, so maybe we're not correct, but they still have respiratory integration, circulatory integration, and homeostatic integration. And we know that patients that have those three spheres of integration around are still alive. Whereas in cardiopulmonary death, you've lost three spheres of integration. In whole brain death, you've lost three spheres of integration. And so we know that those patients are dead. And so she wasn't even close to being brain dead. And brain dead by the current standard, she didn't make that either, because you need to have loss of respiratory integration and loss of mind-body integration. She only had loss of mind-body integration. She wasn't on a ventilator. So they're two completely different things. Now, was she a vulnerable patient? Yes. Was she exploited? Yes. Basically, what happened in her case is they decided that fluid and nutrition was a medical treatment. It wasn't care, and therefore they could withdraw it. And so they stopped giving her food and water, and shockingly, like anyone, died.
And as we know from Catholic ethics, food and water are ordinary means, proportionate. Everyone needs food and water to survive. And so if you
Mhm.
take away food and water from anybody, they're going to die. And that's what happened, as you mentioned, to Terri Schiavo. We spoke a little bit about Jahi McMath, but can you speak a little bit more about her case? She was in California when she was declared brain dead. They had to transfer her. Can you talk about how they came to that determination of brain death? And then obviously her family took action to move her from there. And as you had mentioned previously, she did live for another few years.
Right, correct. So basically, she actually, I believe, had three determinations of brain death, separate determinations in California. And family refused and said, we don't believe that she's dead. So they were allowed then to move to New Jersey because there was an exemption there. And like I said, she was on a ventilator, right? And she underwent puberty, right? And, she started having cycles. Now, again, corpses don't have cycles, human beings have cycles. And she was able to, you know, even some people thought that she was showing some degree of recovery, like Alan Schumann met with her on a number of occasions and thought that maybe she was, again, another false positive. Maybe it was even worse than, this partial brain death standard, maybe even worse than that. And the real problem again is damaged tissue is not dead tissue, right? And so damaged tissue can still function. Dead tissue cannot function. And she clearly had functioning of the brain. She, at best, was what I would call partial brain death, right? Because she did have hypothalamic functioning. We know that. And so she was not dead.
And you mentioned that there are some cases where people who have been declared brain dead have been able to gestate pregnancies. Can you give some examples of some of these cases?
Well, so for example, I mentioned it earlier, this last summer in Georgia, there was a case where, she was declared brain dead, but she was gestating a pregnancy. And, the big question was, if she's dead, what should we do? Should we terminate the pregnancy? So right now, they're now having to act against the body who's trying to maintain this pregnancy, right? In the UK, we see this a lot more often because they have a brain stem death standard, right? And they make no bones about it. This is a functional stipulation, so they're not even looking for whole brain death. And so there was a case of a gal who was maintained on a ventilator for like 120 some days and gave birth to twins. Corpses don't give birth, right? Human beings give birth. And so, and this ability of these patients that have been declared brain dead, but then can gestate pregnancies has led to this idea of what's called whole body gestational donation, where you basically inseminate these chronic brain dead patients to maintain other people's pregnancies. So you're basically using these people for their fecundity.
That's horrific that that's even happening. I haven't heard of that.
I don't know that it's happening. It's been proposed. The
Okay.
person who proposed it is out of Norway. She's also the first editor for the Oxford Handbook on Bioethics.
Well, I mean, obviously that goes to the point of that we ends don't justify the means. You can't use another person in whatever state they're in for something like that. So that's horrific that that's even being considered or thought of. I also wanted to now talk about organ donation, specifically as it pertains to determinations of brain death. If there is even a small risk that someone declared brain dead is biologically alive, what does that mean for organ procurement?
Well, I would argue it would mean that you shouldn't be taking that organ, right? For any of the reasons that we talked about it. But I think Professor Gomez Lobo in 2008 at the President's Council stated beautifully, he stated, if a certain standard or criterion, no matter how widely accepted, entails the risk of violating the dead donor rule, then it should be revised in light of the empirical evidence. If it turns out that the current neurologic standard allows, in certain cases, the extraction of organs from individuals who may still be alive, then the morally right thing to do would be to abandon it and adopt a safer criterion. And if we look at what the church says about this, basically, John Paul II stated that, again, like I said, brain death could potentially be death only in cases of complete and irreversible, and that's a direct quote, complete and irreversible. He stated that you needed informed consent and you needed prudential certitude in the clinical criteria. So in cases where we think they're alive, I would argue we don't have prudential certitude. So we should not be extracting organs from these patients. And I love what Benedict XVI said in true German fashion. He stated, and I quote, individual vital organs cannot be extracted except ex cadavere. So that means from a cadaver. And again, cadaver is not a human being.
Right. And the ethical and religious directives for Catholic health services says that organs may never be removed until it has been medically determined that the patient has died, quote, in accordance with well-founded medical criteria that establish with moral certitude that death has occurred. And what would give us enough moral certitude?
Well, so at this point, I would argue we don't have moral certitude. I think if we were to increase and to improve the testing, In a number of ways that I have outlined, I think we could get there. But in the end, I think we need to think of, sort of going back to that idea of intrinsic human dignity and why we do things. If we look at the Catechism 1912, they're quoting Gaudium et Spes, and they state that the order of things must be subordinate to the order of persons and not the other way around. So, as great as organ donation is, if we are killing people to get their organs, we are violating their intrinsic human dignity, and we cannot be doing that. Now, organ donation could potentially be acceptable, and it is probably acceptable about half of the time. But I would argue that half the time doesn't meet what is determined to be prudential or moral certitude. In fact, it was interesting. The Catholic Health Association had a book club looking at Dr. Eberl's paper and Dr. Solmazian, my paper, and our colleagues from Georgetown. And the people online, the hospital administrators and ethicists, basically said that Dr. Solmazi and I didn't understand what moral certitude was. And
Mm.
so therefore it was okay to keep going with the status quo. Unfortunately, I think I do understand what moral certitude is. And unfortunately, I don't think we have moral certitude at this time.
That's correct. And just to clarify, moral certitude and prudential certitude are the same thing?
Correct. We use the term prudential certitude in the secular medical literature because using the term moral is, somewhat verboten.
And how certain is certain enough? Or are you saying that basically right now it's not certain enough because of the criteria?
Well, so if we think about it legally, right? So, beyond a reasonable doubt, right? So if you could say, hey, these criteria, are right, again, we're never going to get absolute certitude, right? But if you could say, these criteria are correct, 99% of the time, well, okay, sure, that's probably prudential certitude, right? If you were going to give a number to that, just legally, sort of a reasonable person standard. But if the guidelines are wrong half the time, and again, I say that because we know from retrospective data that half of the patients determined to be brain dead by the current guidelines have persistent neuroendocrine function. I would say that if we're wrong half the time, we don't have any sort of certitude. I mean, that's like the weatherman. They're wrong all the time. We joke all the time how inaccurate the weather is. We shouldn't be treating death that way. We shouldn't be treating patients that way. I mean, if I have something, where I'm going to be wrong half the time, I'm not going to recommend, that test or that procedure because you're going to harm the patient.
Based on what we know about how death is currently determined, would you feel comfortable being an organ donor?
Well, so that's an interesting question. So I am an organ donor. I can take out my driver's license because that organ donation is a great thing. But I've developed an organ donation card that you can put with your driver's license to say, hey, I'm willing to be an organ donor because I think whole brain death could be death, and I don't want to be subjected to procedures like normothermic regional perfusion, and it lists a number of guidelines. So I am an organ donor, but with the caveat of I'm an organ donor, but we need to improve testing.
Is that card available to our listeners if they want the same?
Absolutely. I will 100% give it to you and you can put it on the website.
That's great. Um, personally, I think that if they get it wrong 50% of the time, I'm not sure that I could be an organ donor based on that. But obviously, I believe that organ donation, when it's done right, is a beautiful and generous thing to do. I just worry because of the current criteria for brain death and other things that it's not done right. They're rushing people to take their organs, and that's another conversation about organ donation. But it's certainly great to have at least to know that you have a card or a criteria that can be used by people who want to be organ donors to put a level of I guess safety or caution
Mhm.
when they do that.
Well, and it's funny, someone asked me, they said, well, what if they don't follow it? I said, well, if they don't follow it, I'm dead anyway. So the only thing I can do is haunt them. So in the end, I've done the right thing. And I said, look, I would like to be an organ donor. Now, the other thing we need to talk about organ donation is that, you know, when someone at the DMV asks if you would like to give the gift of life, there's no way we can confuse that with informed consent. It is not informed consent. It is assent at the best, meaning that, yeah, I assent to this, but, you know, people, are undergoing procedures, like that normal thermic regional perfusion, that they're not even sure that are being happening. In fact, I know in at least 3 hospital systems, Catholic hospital systems, where these procedures that are clearly unethical are being done. And, the urban procurement organization comes in and just does it. There's no consent for these procedures. And I think the OPOs, the Organ Procurement Organization, really need to clean up their act. They really need to be transparent about what's being done. All this smoke and mirrors is only, wildly hurting public trust. And in fact, in Arizona this last summer, in the month of July, they lost 2,000 organ donors off the registry. And to be clear, so when you go to the DMV and they ask if you want to be an organ donor and you say yes, that's on your license, but then they notify the registry. Well, if you decide to change that and you tell the DMV the next time, no, I don't want to be an organ donor, they don't necessarily tell the registry. So you might still be listed as an organ donor. So if you want to change your status, you have to be very clear about that. He does not believe in that. And the OPO was like, no, it's on his driver's license. We're going to take his organ anyway. And I told them, it came to the ethics committee, and I said, look, you can take his organs over my dead body, but that's not going to happen because he did not have informed consent. And maybe I shouldn't have offered my organs and readily to them, but they probably get fatty liver disease from me anyway.
Well, you make a very good point about the importance of informed consent and true informed consent, and that the fact that what you're getting at the DMV is not informed consent. And so, any guidance we want to link to any documents, etc., that you may have uh, of what informed consent should look like as well.
Okay, I'll see if I can't dig something up. I'm sure there's
Sure.
something good in the literature looking at it. And
Yes.
then to go back to your question about sort of certitude, um, in determination of death, I would like to sort of give you a couple of quotes so we can, so people can think about this a little bit more. So in 1981, the Catholic philosophers Grisey and Boyle stated in the President's Commission looking at death determination, they stated, where experts disagree, those who are not expert have reason to doubt and have no basis to proceed with confidence in a matter which required certitude beyond a reasonable doubt. Right? I think that describes right now perfectly. And it says, when it is not absolutely necessary to proceed, and although it may be necessary to ignore the needs of some bodies, even live ones, it is never necessary to consider any body dead who might be alive. Like there's no reason. Like there's no reason to do that. And then, as Dr. Pellegrino, one of my heroes, stated that when we talk about prudence, there's 2 principles at action. First is the precautionary principle. So when in doubt, act to avoid the greatest danger. And the principle of proportionality. You got to properly balance the benefits and the burdens of treatment. And so when we talk about prudential certitude, we're also talking about the precautionary principle. We're also talking about the principle of proportionality. And it's not black and white. And again, like I said, we're never going to have absolute certitude, this side of heaven. But we can get prudential certitude.
And thank you for offering more information, clarifying that so that our listeners can understand better what it means to have prudential and moral certitude. Looking at some of the cultural and religious dimensions now, you note that Western traditions locate death in the body, while some Eastern traditions see death as a process. Does medicine need a metaphysical grounding?
I would say yes. I mean, diseases exist, they're objective. Objective reality is necessary. And a determination of death must be objective. So someone criticized us once and said, well, you guys, you're just, it's just death is a value judgment. And we said, no, death should not be a value judgment. And in fact, I'll quote us. It says, the determination of death is a judgment of fact, not a judgment of moral value. If it were, there would be no difference between judgments of facts and judgments of moral value. We would all be living in the world of, quote, alternative facts. And we would all be able to say to each other about things like the diagnosis of lupus or the results of an election would be, you have your facts, Matt, and I have mine. Death isn't like that. Death shouldn't be like that. And in fact, intrinsic human dignity demands that death be an objective reality, because again, we shouldn't be attributing death on other people. However, on the flip side of the coin, like I said, I've got no problem with New Jersey's law that states if someone doesn't believe, if their heart is still beating, that they're not dead, that they shouldn't be declared dead. I wholeheartedly agree. But the thing is, if they truly are dead, if they're truly whole brain dead, if they've truly lost self-integration, it's going to make itself known very quickly.
Right. And I like that you focus on the fact that there's a biological reality of what death entails, and it can't be a judgment that's just based on someone's thought or judgment of it, as opposed to actually looking at what's happening in the body. So if you could change, I would say one or a few elements, if you could sum up, of current brain death determination tomorrow, what would it be?
I think probably the best thing we can do. So again, there's a number of things that we need to be doing. So I'd say probably the two big ones are we should be, waiting longer, right? We really need to let the disease process take time. And in fact, when we look at the data, right, specifically like neurotrauma, they show that if you wait 72 hours, patients actually do better. And that's just following the science, right? Yes, it's more, it costs more to keep someone in ICU for another day or two, but cost shouldn't matter, right? Now cost does matter, right? But it shouldn't matter when you're making a determination of death, right? You shouldn't say, well, if you could afford the extra 2 days, we would wait. No, we should be waiting, right? It should be good science, right? And then in addition to that weight, I would say, look, we really need to make sure that these patients don't have hypothalamic functioning, whether or not that's using a four-vessel angiogram to determine it, whether or not it's looking for clinically for diabetes insipidus, whether or not that's sort of blood test. If we did that, I mean, we would improve certitude significantly. And, would it be perfect? No, it's never going to be perfect, right? But would it improve certitude? Absolutely. And so, like I said, if I could just have two things, that would be great. If I could have just one thing, it'd probably be say, hey, test that hypothalamus, right? Because we know that it's wrong half the time.
It just seems like this is such a common sense addition to the current criteria, and that it wouldn't cost much more. And even if it did, it should be done if it provides more certitude.
Well, I agree. That's what good medicine looks like.
That's right. And so I think these are very common sense additions that should be considered, and not only should be considered, but seriously taken and added to the current criteria. Does redefining death risk eroding trust in medicine?
Well, I would say the answer should be obvious. I mean, when you look at all the corners that have been cut by the OPOs and the HHS looked at it and, pointed this out. You get people that are taking their names off the organ registry. I mean, yeah, it definitely is eroding trust in medicine. I think if organ donation is going to continue, we need to acknowledge that our current criteria were wrong. We need to be willing to change and to improve testing. And guess what? If I'm wrong and whole brain death isn't death, right? If the prospective data shows us that even if they're whole brain dead, they're still not acting, they're not losing self-integration, then I need to be humble enough to say, look, I was wrong, right? And I need to move on and improve testing. We really need to be honest. We are fallible, right? We are not God, right? And and we're doing the best that we can, but we need transparency. We need to have informed consent. We need to be clear about what's happening to these patients if we're going to improve public trust. I mean, look at, public trust. It was very interesting to me that the UDDA revision occurred right after the COVID-19 pandemic. I mean, talk about a public trust nightmare, right? I remember at one hospital, um, they they mandated masks a week before um, the safety data came out for the COVID vaccine, saying, yeah, it was okay, right? And I'm like, why? Why would you do that? Just wait a week. Like, just wait. You could have waited a week and you would have improved public trust.
Yeah, no, I think this is very important in building public trust, especially as you said, if people, the healthcare system wants people to continue to consider organ donation. If not, we have the problem of what's happening in China, which is that they're killing people for organs. And that's a separate issue that we've talked about in a different episode. But you talk about the Goldilocks problem in the determination of death. Not too hot, not too cold, just right. What does just right look like?
So I believe that just right is upholding a whole brain death standard. So we've used this analogy. So we recently had an article in National Catholic Bioethics Quarterly, Dr. Solmesi and I, and it was called Goldilocks and the Determination of Death. So to me, those that are too cold are saying the status quo is fine. We don't want to look at the data. We don't care, right? That's rather cold, right? I think the too hot people are those that are wanting to throw the baby out with the bathwater. Right now, we have data to say that whole brain death could be death, right? And 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 the problem is, like, there was a statement that came out. It was Catholics United Against brain death, and it basically said we don't have moral certitude, so Catholics should not be organ donors. And I didn't sign that statement. And one of the reasons I didn't sign it is because there's this old adage: if you're not at the table, you're on the menu. And so if I believe that organ donation is a great good, and I believe that we can improve certitude, and actually what's very interesting is the reason the UDDA revision was placed on hold is that the American College of Physicians, the second largest physician organization after the American Medical Association, stated just that. We need to improve testing. In fact, the American College of Physicians is 4 times larger than the AAN, the American Academy of Neurology. The American Medical Association never said anything. So right now, secular medicine is asking for us to improve testing. So we need to take the bull by the horns and we need to do it. And it's not difficult. We just lack the will to do it. And what I don't want to have happen is for our idea of improving testing to be thrown out, throwing the baby out with the bathwater, or not being even accepted because, well, it would potentially cut the number of organs available for donation in half. So, for example, this weekend they're having a meeting for the Society of Christian Bioethicists, and they're having a debate about brain death. And the two camps are: is brain death is fine the way it is, and brain death doesn't exist. Our point of view is not even represented. We were not even asked to take part in this, and it's a shame. I think we have a great opportunity to practice good medicine, to improve public trust, and to uphold the intrinsic human dignity of the patient. And that's what just right looks like. And so, when I educate people about this, I sort of, compare things. So if we were to keep the current clinical criteria, then dead enough becomes the standard of death. Death is based on a functional stipulation. We eliminate certitude. We violate intrinsic human dignity, and we're procuring organs from the biologically living. If you were to expand the clinical criteria for whole death, all death would be death. Death would be based on biology. We could achieve certitude. We would promote intrinsic human dignity, and we would be procuring organs from the biologically dead. Now, if the prospective data that's being gathered proves that we're wrong, then we need to be willing to change because we're not We're not infallible. So that's just right.
I think that that's a very middle way of going about this and the correct way too. I agree with you on this because it's better to be safe than sorry. Why not
Yep.
add more criteria that can give us more of a prudential or moral certitude about the condition of the patient and whether that person is actually dead or not. I think that more information, more biological data will help us determine that. And so
Hmm.
that's important. And if we can do that, we can come to a conclusion based on biology, not on uh, judgment, on someone's subjective judgment, and it could actually help determine the actual condition of the person. Finally, what is one takeaway you want our listeners to keep in mind when they think of brain death?
So probably the takeaway I would say is you need to educate people about this. The vast majority of people don't know that this is happening. I mean, there's been pushes to make organ donation mandatory for everyone, and you can potentially opt out of it. That's one idea. Like I said, the AAN is going state to state, trying to get their standard enshrined in the law of your states. I think people need to be aware. And in fact, they recently came out with an article. It was entitled Brain Death by Neurological Criterion, Guidance on Communication Objections, Pregnancy, and Public Trust. And it's a position statement of the American Academy of Neurology. And a friend of mine stated that basically they, quote, increase trust in their standards by allowing for no dissent. Now, the first thing I think of when I think of that is I think of Buddy the Elf. You sit on a throne of lies. But we've got to remember these people are not bad people. These guidelines are not bad guidelines. I think what's happening is that people are losing sight of the patients, right? They're so focused on this great good of organ donation that they're losing sight of these vulnerable patients. And there's actually a term for that. That's called teleopathy. It's pathology of the goal. And so I think we have to be very, very kind with people that disagree with us. I think we need to be educating people. I think we need to be having these debates. And I think we need to be humble. We need to accept if we're wrong, then we need to do better. And ultimately, that's probably the hardest thing to get over is our own egos.
Well, thank you, Dr. DeCock, for your expertise on this. I hope that people walk away understanding better what brain death is about and currently what is happening with the criteria, how it can improve, and that we can get to a point where we put patients first, people first, and that the ends don't justify the means, that just because organ donation is a great good, not all roads to organ donation are ethical. And so refining the definition and the criteria for determining brain death is a number one step in determining that. So thank you for helping us figure out these nuances. And we appreciate having you on the show, and we definitely will have you back.
All right. Well, thank you very much. I appreciate it.
For my conversation with Dr. Christopher DeCock, a pediatric neurologist and epilepsy specialist at Essentia Health, a clinical professor of pediatrics at the University of North Dakota School of Medicine and Health Sciences, and adjunct bioethics faculty at the University of Mary, here are my 5 key takeaways on the criteria for determining death. 1. Death is the loss of the organism as a whole, not just the failure of individual organs. Death is the loss of the body's ability to function as an integrated organism. Individual organs can continue functioning for a time, but what matters is whether the body still operates as a coordinated whole rather than a collection of parts. 2. Brain death criteria aim to identify this loss of integration, but the current criteria is not enough. Current medical standards, largely shaped by the American Academy of Neurology, use clinical tests such as coma, absence of brainstem reflexes, and apnea testing to diagnose brain death. But these tests primarily assess brainstem function and the ability to breathe independently. They do not test for all brain activity, and patients diagnosed as brain dead may still retain functions such as hypothalamic regulation of hormones, temperature, and stress responses. Because of this, the current criteria may not truly demonstrate cessation of all brain function, and thus a true biological death, as the law requires. 3. Some patients diagnosed as brain dead still show signs of biological integration. Cases discussed in the interview raise challenging questions. Some patients declared brain dead have maintained hormonal regulation, temperature control, puberty, or even pregnancy, suggesting that certain brain functions may persist. 4. The distinction between irreversible and permanent cessation is ethically significant. Irreversible means a function cannot return, while permanent means it will not return because no attempt will be made to restore it. Conflating these concepts can shift the meaning of death and raises important ethical questions about how death is declared in modern medicine. 5. The stakes of getting death wrong are profound. Accurately determining death is foundational for medical ethics, public trust, and practices like organ transplantation. If death is the boundary between treating a patient or procuring his or her organs, the criteria used to determine death must give strong moral and medical certainty that the person has truly died by all biological information available. Because truth matters and human dignity isn't optional. This is Bioethics Babe. Thanks so much for listening to this episode of the Bioethics Babe podcast. If you've enjoyed this content, please subscribe to my YouTube channel and your favorite podcast platform, and share with your friends and family. Also check out bioethicsbabe.com for the latest episodes and resources.